and we can interact. So first phase is this, and it is acceptable. There are unusual cases that I have got. This you can see a tumor in the septum, posterior half, daily, and both sides epithelialized. You can see a big tumor, and blocking the nose, posterior vena, and endoscopically it was done. And it was well separated from the encapsulated, rather you can say it like that. So, by the endoscopic approach, if I remove it, was blocking the ostia of the or the anterior wall of the sphenoid sinus, and this tumor was completely removed. Then the biopsy came adenomyosis carcinoma, and the patient was subjected to the radiotherapy. There is a slight controversy in such type of cases because some of the time it is recommended, some of the time it is not recommended, but it's almost now 13-14 years, and patient visited me last month and perfectly okay. So just limited tumor and assessment of the tumor with the radiological and clinical examination is very, very important to decide and to do. And the complete tumor was removed. They are not big videos, it says 2 minutes, 3 minutes maximum. And complete removal cannot be done to the nose, so part of it which remain is removed. And the patient is perfectly okay till date. Only posterior part of septum is not there, and the sphenoid is open directly, but no disease, no polyposis. These are some of, this is some type of abnormal or unusual presentation. So adenoid, the histopathology being adenoid cystic carcinoma. Then this is another view. Can anyone brief what this can be? Again, what the extension? Some of the time the presentations are such unusual, and it looks that what we will come across while during the surgery, so we prepare everything. No. It was not my case, it was my associate case, and he told that there is some entrogonal polyp. So, when I reached to the operation room to do it, so he said it does not look like to get polyp, because the medial wall is completely eroded. Whole of the maxillary sinus is involved, and you can see
there is hyperkeratosis or new osteogenesis.
you can see this bone intact here. Septum is pushed opposite. So anyway, so I was well prepared. I told my anesthetic that I may have the, it looks, it may be inverted papilloma, so he may have the more bleeding. That is the major diameter, and just see how they present. Some of the time they present very different. I thought it is a very big tumor, and that's so I thought it was to slight debulking. And Dr. Ravi had told that we must to start debulking so we get the access, and we can remove it from the attachment. By the bipolar forceps, suction bipolar forceps, I try to cut it so that I can reach the above and literally and medially remove it. Then I was able to see slight attachment on the septum. And this was the total attachment. Will be removed and totally everything is here. It was expansile and causing the pressure on the medial wall of the maxillary sinus, pushed it, and that was the total attachment. So some of the time the presentations are different, and there is no all mucosa is otherwise normal, but the middle remnant pushed, upper portion pushed, the medial wall of the maxilla pushed, maxillary sinus completely filled by the tumor. Septum was pushed, but the attachment was only this small, hardly 5 millimeters. So, anybody can comment? This one of my class fellow, very famous neurophysician of one of the state, called me that Sharad, I am having headache and I got the CT scan. There is some finding. Just go through this finding. I said, there is a gap, there is a mass, it looks to be encapsulated. Otherwise, there is no destruction. Even the anterior wall and everything, like the ostium is blocked. You can see in the lateral, the sagittal sections, you can see in the axial sections, there is a slight.
The IC is completely.
Yes.
IC, posterior wall is
Posterior wall, and here is the IC. So, is it benign or malignant? How we can say bone erosion is there, this is expansile, carotid is exposed.
That is also happening benign.
Rheumatus.
Contrast enhancements that the pictures are just.
So, unfortunately, he told me that I can come to Delhi to get operated. Or I said, no, I will come, I will operate at your hospital, where he was working. So there is another ENT surgeon who is also sitting near to me. So he said, okay sir, most welcome. I went there, but recording could not be done for this surgery. I told them, they said, yes sir, recording. But recording could not be done. But there was only photographs were taken. So I did the surgery endoscopically, opened the sphenoid and enlarged the opening and found encapsulated tumor. And it is a tumor was exposed, the orbital and the optic nerve was exposed. There was no bone in the carotid optical recess, and there, but the tumor could be removed completely. And as Dr. Ravi said very nicely that pathologist must be there. The pathologist is the adenoid cystic carcinoma diagnosis. But I said, just get it checked again. And then the biopsy was, and the slides and blogs were sent to the Bombay and what is, and she said spindle cell tumor. And then he took opinions and corporate, nothing was done. Now it's almost 3.5 years. No difference, nothing. The CTs were done later on, but there was no problem. The sphenoid, the inverted papilloma, we find maximum in the macular sinus, medial wall of the macular sinus, and that. But I have done few cases, not one or two, few cases of inverted feckloma of the sphenoid. It's a small video, and it gives also a presentation like a polyp or some, but not the look is not the polyp. So it gives a different look, not malignant, but still difficult to assess what it may be. And when the surgery was done, and it was from the anterior wall, anterior wall of the sphenoid sinus below the ostium. The complete removal and the enlargement of the ulcer. And the patient is perfectly, whatever patients I did about the sphenoid sinus, more than 2 cases, and every okay. Only thing is that you have to do good enlargement of the sphenoid sinus. So I took the advantage of the macrotic rider, but the pathology may be different. So we may not say that this is the inverted papilloma only on this one. This is another case. Just we were discussing one CT scan regarding the ossified fibroma. This is a usual patient and a child with the diagnosis of ossified fibroma. Eye pushed, bulge on the palate also, on the sublabial region also, and this was the same. So you can see hole in the axial EPC, bony walls are all eroded all around. So what is your any comment? Circumscribed, you can see. But erosion of the bone is also there, going to the pterygoid and fossa also, and going to the orbit also. In this, you can see the pushed in the orbit also, opposite side also. Bone cyst. So, some of the time, coccygeal fibroma, fibrodysplasia, individual bone cyst, they are also present differently and may be confused. And by the sublabial incision, the surgery was done, and in toto it was done. So, this we did in the month of July. This is another case. Any diagnosis? Anybody? So it is also unusual. Normal cyst is also unusually presented, but yes, I have seen number of cases.
Not as big as this.
And 32 age. So it's unusual at this age. But that is, Dr. Ravi, in the case which I discussed with you, that is a different one. But picture of the radiology is almost the same.
Yes.
Good sleep.
Basically, you need a contrast agency or an MRI.
So with the microdebrider it's now very easy.
The problem with microdebrider is that it will not leave tissue biopsy specific.
Yes.
So that is
Diagnosis they cannot say the complete.
all nasal tumors and the tumors which are being guided by microdebrider, you should take multiple biopsy in between and send the specific. That will actually take care of the.
I've tried to use a filter, but it is not very successful. A trap kind of a thing, I've tried that.